I'm John Strum, and this is Real Talk MS. It's August 23rd, and we have a lot to talk about. Compared to men, women are roughly 3 times more likely to develop MS. But when men do develop MS, they're more likely to experience a more aggressive disease course. Men are more likely to experience motor problems, loss of coordination and balance, and cognitive issues. When they experience a relapse, men are more likely to see their exacerbated symptoms continue even during times of remission. Men tend to see their MS progress faster, and compared to women, men living with MS are more likely to experience greater brain atrophy. Now, given these evidence-based observations, it may be equally surprising to learn that as they develop MS symptoms, men are less likely to seek medical attention or even get a diagnosis. Returning to the podcast to discuss MS and men is Dr. Robert Shin. Dr. Shin is a professor in the Department of Neurology at MedStar Georgetown University Hospital, and he's the director of the Georgetown Multiple Sclerosis and Neuroimmunology Center. But before we get to my conversation with Dr. Shin, there are a few other things that you should know about. In last week's episode of the podcast, we took a moment to celebrate the Inflation Reduction Act, the largest and most consequential healthcare bill since the Affordable Care Act. This new law is a significant win for all Americans, and especially anyone living with a chronic illness like multiple sclerosis. If you're interested in learning how and when this bill will impact the price of your disease-modifying therapy and other prescription drugs, the National MS Society is hosting a webcast that will explain the implementation timeline and the impact on drug prices that this new law will have. The webcast takes place this Thursday, August 25th, at 11 a.m. Eastern Time, and you'll find the link to register for the webcast in today's show notes. Imagine a time when your neurologist or MS specialist could accurately predict the severity of your future MS-related disability, even before you had experienced any or many symptoms of MS. Armed with that information, choosing a more aggressive treatment plan might mitigate what that future outcome would actually look like. Newly reported results of a study from Austria may have brought us a step closer to the day when this imaginary scenario becomes a reality. Now, previous research has shown that the retina is thinner among people living with MS. Scientists and clinicians sometimes say that the back of the eye is a window into the front of the brain. And a research team from MedUni Vienna, University Hospital Vienna, wanted to determine whether measuring the retina following an MS relapse might provide a measure of damage in the brain and be predictive of the severity of future relapses. The team studied 167 people with MS over a period of about 3 years. Using a highly specialized measuring technique called optical coherence tomography, or OCT, the researchers were able to confirm that the loss of approximately 5 micrometers, or a microscopic 5 millionths of a meter, in retinal layer thickness equated to doubling the risk of permanent disability that someone would experience after their next MS relapse. This is the sort of information that a clinician and patient can put to good use in determining proactive treatment options. Now, the good news here is that the measuring technique, optical coherence tomography, is already used for diagnosing other eye diseases like glaucoma. So it would be relatively simple to add this retinal layer measurement to anyone's regular 6-month or annual appointment with their neurologist. Now, this groundbreaking study involved 167 study participants. The next step should be larger studies designed to validate these results, and then perhaps we'll arrive at a time when using OCT to measure retinal layer thickness as a biomarker for future disease progression will be as commonplace in MS treatment as an MRI is today. If you'd like to review the details of this study, you'll find a link in today's show notes. There's some discouraging news for people living with MS in the UK, where government officials announced that the National Health Service would not be purchasing the COVID-19 drug Evusheld, which has been shown to be effective in preventing the COVID-19 virus from attaching to or entering human cells. Now, this has been especially important for people living with MS who are on B-cell depleting disease-modifying medications like rituximab, Ocrevus, or Kesimpta. In March of this year, the UK government's independent expert scientific group, the Commission on Human Medicines, gave their approval of Evusheld for adults who are immunocompromised. In the United States, the National MS Society recommends Evusheld, citing published evidence that shows Evusheld was effective in allowing study participants who were on B-cell depleting DMTs to develop a higher number of antibodies. Now, the UK has been known to reverse its own healthcare decisions, and we certainly hope that the outcry from people living with MS, along with major MS patient organizations in the United Kingdom, will prompt the government to reconsider this decision as well. As we have in today's episode of Real Talk MS, we often talk about scientific discovery and emerging treatments that will fundamentally change the way someone might live with MS. My friend, artist Elizabeth Jamieson, has discovered another form of therapy, and she recently shared it in an editorial published in the Washington Post. The title of Elizabeth's editorial pretty much sums up her discovery. It reads, "How I Learned That Swearing Can Be Good for the Soul." Elizabeth is living with progressive MS. In her editorial, she explains that she can't drive her own wheelchair or hold a cup of coffee. She can't scratch the itch on her nose or quench her thirst unless someone else lifts a cup and straw to her mouth. She has to be fed by others who don't always know how to offer up the right thing at the right moment. Now, as an artist, Elizabeth used to load up her paintbrush with a thick gob of paint and then hurl it against her studio wall as a way of releasing her frustrations. But losing the use of her hands put an end to that therapeutic indulgence. What Elizabeth has discovered is the power and freedom from her otherwise overly controlled and dependent life by just letting loose and cursing. And although she's peppering her language with the kinds of four-letter words you wouldn't expect from someone who early in life hoped to become a nun, Elizabeth isn't swearing at anyone in anger. It's a defiant breaking the rules of how one should act. It's raging against not any one person, but against the universe. Poets and philosophers have long pondered what happens when we gaze into the abyss. Elizabeth Jamieson has found a fulfilling response in tossing an F-bomb into the abyss. If you'd like to read Elizabeth's editorial, and I sincerely hope you do, you'll find a link in today's show notes. As I mentioned in the opening of this episode, MS affects men differently than women, and results from a study conducted by a research team at the Cleveland Clinic indicate that men react to and experience MS differently as well. Traditionally dominant masculine ideals often include toughness, resiliency, independence, and stoicism. And I think it's fairly easy to see that these kinds of culturally inflicted aspects of gender identity all work against someone asking for help. Previous research has shown that men allocate less time to their personal health and practice fewer preventative health behaviors when compared to women. Published research has even provided evidence that men between 16 and 44 years of age perceive the medical setting itself as more feminine, and therefore tend to underutilize health services. The Cleveland Clinic research team wanted to explore these cultural gender norms and health behaviors among a group of men receiving treatment for MS at the Cleveland Clinic Mellon Center for MS. And the team wanted to further explore how the relationship between this cultural definition of masculinity and health behaviors had an impact on the way that men coped with living with MS. 500 men who were being treated for MS at the Cleveland Clinic were invited to participate in the study. 81 completed the study, which involved responding to a series of surveys that were used to measure how they conformed to cultural masculine norms like emotional control, the desire to win, self-reliance, and risk-taking. There was another survey that measured how much the respondents used a particular coping strategy in response to a stressor. There was a survey that measured the study respondents' health behaviors, measuring whether they paid attention to their diet, used healthcare resources, and took advantage of preventive self-care. Finally, study participants were asked to measure the impact of MS by assessing their own level of disability. Among the study participants, the average age was 51. The mean time since diagnosis was 12 years. More than 90% of the participants were white. About half were college educated, and 20% were married. So we're talking about a group of older white men, which may or may not be fully representative of all men who are living with MS. After performing a detailed statistical analysis of the various survey results, it was shown that men who reported a greater need to appear heterosexual were more likely to engage in self-care. Men with a greater need for emotional control tended to report poorer self-care. And men with MS who coped by focusing on personal growth also reported greater effort in self-care. Men who considered themselves as having greater physical disability reported taking greater effort to control their anger and stress. And men who reported themselves as having a penchant for violence made less of an effort to control their anger and stress. The research team noted that masculinity adherence to gender norms was a significant predictor of how men engaged in health behaviors. And beyond just summarizing and presenting some interesting information, this is the kind of information that can help inform clinicians on the effort needed to successfully connect men with MS to resources that can empower them to better manage their MS, and in doing so, improve their quality of life. So it would seem that men with MS not only face a more difficult disease course, but many of them don't necessarily help themselves when it comes to making things better. In a moment, we'll meet my guest, Dr. Robert Shin, and we'll take a deeper dive into better understanding MS and men. MS impacts women almost 3 times more frequently than men. But research shows that men often take longer to report their symptoms, get a diagnosis, and begin treatment. And when it comes to getting support, well, that's one more thing that men often find challenging. Today we're talking about MS and men with Dr. Robert Shin. Dr. Shin is a professor in the Department of Neurology at MedStar Georgetown University Hospital, and he's the director of the Georgetown Multiple Sclerosis and Neuroimmunology Center. Welcome back to the podcast, Dr. Shin.
It's a real pleasure to be back speaking with you, John.
As we begin our conversation, I just want to take a moment to acknowledge that sex and gender exist on spectrums. And today, we'll use the terms male or men and female or women to refer to a person's sex assigned at birth. So to get into our conversation, we know that early diagnosis and early treatment lead to better outcomes for people living with MS, a better quality of life, fewer debilitating symptoms. But research shows that men take longer to report symptoms or get evaluated for MS, and they often start treatment later. Do we know why this happens?
Well, it's an important observation. As you pointed out, we know that early treatment of multiple sclerosis is going to be associated with a better outcome. So delays, which you just brought up in terms of either seeking medical attention or being diagnosed and treated for MS, are going to result in real differences in outcome, meaning if it takes us longer to make the diagnosis or people start treatment later, they may be at risk of greater disability. Now, for men, there can be differences. Certainly, there are gender sort of stereotypes in which, in our culture, for instance, men are discouraged from even recognizing that they need to seek medical attention. So there's always a feeling of, hey, shake it off, or hey, man up. And so one source of the delay could be that men themselves are less likely to notice or identify or even mention if they're having a subtle symptom, like a little bit of numbness and tingling, or, a little bit of mild dizziness even. So that could be part of the delay. However, on the healthcare provider side, I think we also might be slower to recognize multiple sclerosis in men. One message that we've driven home time and time again, inaccurately in my opinion, is that MS is primarily a disorder of white women. This is something that's been in our literature and on our websites and in our lectures for decades, and it isn't even really true. Certainly from a race standpoint, it doesn't matter if you're black or white. You have about the same risk of MS, and we need to be attentive to people in the African American community. But this, I would say, would apply to men and versus women as well. Lots of men have MS, and whether there's a small difference statistically speaking, I think the message really should be that men and women can get MS. I think of the National MS Society, the founder, Sylvia Lowry, who did so much to increase recognition of MS and driving. Remember, Mrs. Lowry did not herself have MS, right? It was her brother who had MS, and she was driven to try to find resources to help her brother. And I think of men living with MS who you may have brought up earlier, may be either confused or just feel strange. Wow, why do I have a woman's disease? Or how did this happen? And I think this is really because we have been spreading the wrong message. MS is the disease of men and women. MS is a disease that affects you regardless of race. So hopefully this podcast will, in a small way, maybe change those perceptions so that we can make the diagnosis earlier and get men access to effective therapies earlier.
Well, I certainly share in that hope. We often talk on this podcast about the role that depression can play in living with MS. We know that there are studies showing 1 out of every 2 people with MS will at some point be diagnosed with depression. Do we know whether the incidence of depression among people living with MS is greater for men than it is for women?
Well, it's so important that you've brought this topic to the conversation through your other work, because as you pointed out, mood disorder is surprisingly common in people living with multiple sclerosis and really under-recognized. And there is probably something unique about multiple sclerosis, inflammation within the brain that predisposes to things like mild anxiety or depression. And so it certainly makes sense that that might be even more common than in the general population and more common than in other neurological disorders. Now, when it comes to men versus women living with MS, I do want to emphasize that in the general population, depression is diagnosed more commonly in women than in men. Depending on the studies, it could be anywhere from 1.5 to 3 times as many women as men are diagnosed with depression. But we run into the same challenge we were kind of hinting at earlier, which is that really the true incidence of depression, or is that just more women than men are diagnosed with depression? So I would argue that since we now recognize that anxiety and depression are common in people living with MS, I would say that we should be sensitive to the possibility that we're under-recognizing it in our men living with MS. Partly, again, as we mentioned, because of these gender roles that we've all sort of grown up and absorbed, that men need to be tough and men can't talk about their feelings and men should just, deal with it. Which goes really both ways, both in terms of recognizing symptoms of depression in oneself, as well as for healthcare providers who recognize it in the patients we're taking care of. Now, I would emphasize, as I'm sure you have before, that symptoms of depression can be quite subtle. It doesn't have to be sadness. It doesn't have to be crying. It could be fatigue. It could be trouble sleeping. It could be a little bit of mild irritability. It could be decreased sex drive. All things that actually can be quite common in MS, from MS, but may coexist when there is MS-associated depression as well, again, in men or women.
So when does someone know if it's time to seek professional help in managing mood or depression specifically?
Wow, that's a really important question. My easy answer would be if it even occurs to you, you should you should reach out and at least talk to someone about it. So I do hope that your listeners who are living with MS or who are family or friends of the people with MS can encourage others or each other to reach out if they're feeling certain symptoms, which, as I said, could include things like just being kind of irritable. Sure, low mood could be a part of that, low energy. And I think that if you can have a relationship with a healthcare provider where you can feel comfortable confiding those kinds of symptoms, I think that's going to go a long way to improving our recognition of this very important symptom.
I'm going to move off of depression for a second, but I'm kind of stay with mood, if you will. One of the things that we know about roles as they're traditionally defined by an awful lot of people is there's this concept that a man is, quote unquote, the man of the family. He is the leader of his clan. When a man is living with MS and if it progresses, he begins to realize that he can't do all the things around the house like he used to. He tends to feel like he's letting his wife and kids down somehow as his life begins to evolve a little bit. Do you have any suggestions for how a man can best deal with those changes going on?
Well, it's so important because, as you pointed out, our culture has created expectations, roles that men are supposed to fill. And to be honest, obviously expectation roles that women are supposed to fill. And to some degree, they don't always overlap. But part of the solution, I think, is to not be constrained by those constructs. There's no reason why a couple, let's say, can't redefine what roles each other may fill. Men can be nurturing. Perhaps a man can, I'm just going to make things up, they could stay at home and do different kinds of work if they couldn't get out into the workplace. Maybe traditional roles for, I'm just, again, making things up, I don't know, women cook in the kitchen and men barbecue on the patio. Or, these are in some sense so arbitrary. And I don't think we should let limitations from multiple sclerosis further, if you will, demoralize us, or, we use the word emasculate a man because they may not be able to fulfill some other stereotyped role. So I think really having the conversation and being open to really redefining what it means to be a man or what it means to be a woman for that matter might go a long way to addressing this.
Not long ago, I interviewed Tyler Campbell on this podcast, and Tyler is someone who has been very upfront and transparent in talking about all of the symptoms of MS that he experiences, including erectile dysfunction. And I'm wondering whether something like erectile dysfunction is an MS symptom, is it a side effect from disease-modifying medications or something else? And what's the best treatment plan?
Well, it's so important that you had that conversation and that you continue to make sure that this is part of the conversation. So sexual dysfunction can be common in MS in men and in women. Some of the factors may not be directly MS related. So we just touched on how MS can affect mood. And depression can reduce libido, can reduce your interest in sex, which can in turn result in erectile dysfunction on that basis. In that case, the solution would be to be open and to recognize when mood disorder is present and to see what can be done to try to address that root cause. On the other hand, MS does affect the brain and spinal cord directly. It is a demyelinating disorder of the central nervous system, and thus MS can directly affect erectile function. It can affect sensation, and certainly from that standpoint, that would be an issue for men and women. In that case, the question is, okay, how can we best control multiple sclerosis? What are the latest therapies to help, really separate from MS, but to manage erectile dysfunction? And certainly we want to make sure our patients have access to those types of resources. I might also kind of emphasize that we need to, as you're done, be just more open about these kinds of issues, right? Again, the relationship with a healthcare provider is so important. Will men feel comfortable bringing up these subjects to their provider so that we can offer them these options. I think that's so important. The last point you had made is, could erectile dysfunction be related to their MS disease modifying therapy, for example? I'm actually going to make a general statement, even though we now have seems like dozens of different MS disease modifying therapies, different options to treat MS. Thankfully, erectile dysfunction, to my knowledge, is not a direct side effect of these MS medications. Now, having said that, there are many other medications that an individual might be on, medications that might treat blood pressure. To be honest, some medications that are used to treat anxiety, depression, and others that can directly affect sexual function. So if someone is having any kind of sexual dysfunction, or for a man, erectile dysfunction, certainly taking a look at the med list to see if there might be interactions going on is always very important.
Does MS have any impact on a man's ability to conceive with their partner?
Oh, very important question. And again, as a general statement, multiple sclerosis does not affect fertility for men or women. That's not to say there aren't challenges and issues that might come up when talking about conception, how you might time that in relationship to your disease-modifying therapy. Certainly, there are lots of issues for men and women on this subject. But I'm just going to sort of make a general statement that MS does not affect fertility.
We know that support groups can be helpful to anyone living with chronic illness. But because MS impacts women so much more frequently than men, MS support groups are often made up of all or mostly all women. That in itself can be a challenging situation for a man to navigate. So what's the best way to handle this if you're a man living with MS and you know that a support group could be good for you?
Also a very important topic that's even broader really than the subject of men with MS, isn't it? So the idea of support groups in MS, if you will, pros and cons. One of the challenges is that multiple sclerosis, in some sense, is so diverse. As we just made, it affects men, it affects women, it affects people of all different races, it affects people of all different ages, and it can result in quite a variety of disability, from individuals who have no obvious outward disability to individuals who are quite physically disabled, for example. And so one of the challenges of MS support groups is one size really cannot fit all. And so certainly I've heard examples where, let's say, a newly diagnosed individual with MS was almost demoralized or frightened by the MS support, because so many of the people there maybe were there because they did have more disability, and had a completely different issue. We're in a different stage of life, and that was a challenge. But you brought to mind another challenge, which would be, what if you're the only man in a support group full of women? What if you feel uncomfortable in that setting? What if the symptoms that are being discussed are not necessarily symptoms that you perhaps are experiencing or had recognized? I think one of the solutions is that, in some sense, and I would say in the era of the pandemic, we're doing so much more virtually. Perhaps people can connect in maybe smaller ways. Groups that are perhaps a men's support group, for example, would be of value. For some individuals, perhaps a newly diagnosed support group would certainly make sense. I think that maybe efforts such as what you're putting out to get the word out there would mean that, well, maybe more men will be recognized as having MS, and more men will be open to talking about it, which will, in a way, kind of address this problem of better representation. So I think all of those factors are important. Really, the first step, I think, is really the recognition of this challenge.
It's so interesting. I think sort of the underlying theme through our conversation today has been not only about treating MS, but it's really been about addressing the stigma that comes along with some of these cultural/gender sexual stereotypes that we've created in our society.
Absolutely. And it's really not a unique problem to multiple sclerosis. So for instance, in a different context, we talked about heart attacks affecting men more than women. And then tragically, if a woman were to have a heart attack, she was more likely to die. There's a terrible discrepancy here, because it would take doctors longer to realize that the woman was having a heart attack. And so their outcomes were worse. And I would say it's very much the same thing in MS, which is that when we talk about it as a disease that affects women, we are slower to recognize it in men, perhaps slower to treat it in men. And perhaps we shouldn't be surprised that we've observed that men may have, in general, a worse outcome because of that delay. So anything we can do, as we've done with heart attack, which is to take, in some sense, sex out of the equation. We don't talk about a heart attack as a disease of men. It's just recognize the signs of a heart attack, get help immediately. And I think we should be the same way about multiple sclerosis. It's not a disease of men versus women, or it's not a disease of women instead of men. It's not a disease of white Americans instead of Black Americans. MS affects men and women of all races. And we need to do our best to educate the community about the signs and symptoms of MS so that all people can be diagnosed as quickly as possible and be offered highly effective therapies as soon as possible, regardless of whether you're a man or a woman, regardless of whether you're Black or white.
Well, Dr. Robert Shin, thank you for all you do to improve the lives of people living with MS. And thanks so much for talking with me today.
Well, it's always such a pleasure. Keep up the good work, John.
That's going to wrap up this episode of Real Talk MS. Real Talk MS is powered by the National MS Society, and you can share this episode of the podcast by letting your friends or family members know that all they have to do is point their web browser at realtalkms.com/260. You'll find that link in today's show notes so you can easily copy and paste it right into your email or text. And if you have a minute, I hope you'll visit the Apple App Store or the Google Play Store and download the free Real Talk MS app for your iOS or Android smartphone or tablet. It's the best way for us to stay connected. The app will automatically download the latest episode of Real Talk MS. You'll be able to access any of our past episodes. You'll be able to save your favorite episodes, and it's a great way for me to share bonus content with you. The app is free, so I hope you'll download it today. I'm John Strum. Thanks for listening. Stay safe and make healthy choices.